Hello, everyone. This is Eric Crowder. Given that it's 6 o'clock, I'll just have a few brief comments as the chair of the section, and then turn it over to our esteemed speakers. Thank you, everyone, for joining us this evening. Mallory and Allie have been very diligent in fighting through the logistics to eventually settle on this format. We had originally scheduled to have this in-person meeting like previous meetings at their office at Gallagher, Villiers and Jones in Baltimore on what were two very topical presentations that in my view have become even more topical during the pandemic. So I'm looking forward to hearing their presentation, and thank you to everyone who has joined virtually. I see the list of folks on the right hand side of my computer screen, which is numerous. So welcome, everyone. This is the first time we're doing this, but I'm sure everyone generally has the idea, whether on this platform or another electronic video conferencing platform, Zoom, Microsoft Teams, what have you, has gotten used to this format of doing things. So welcome. I will briefly introduce Mallory and Allie, associates with Gallagher, Villiers and Jones, prepared to speak to us this evening about federal regulations pertaining to, on one hand, skilled nursing facility compliance programs, and on the other hand, interoperability rules, both rolled out by HHS. So without further ado, I will turn it over to Mallory and Allie, and please feel free. This is intended to be, as it was in person, an informal meeting. It's a little different virtually, but please do feel free to the extent possible. And Bill, I'm going to ask for your guidance. If anyone does have a question, how can they get Allie or Mallory's attention if during the presentation they want to discuss a particular point they're making?
The best way to do that would be to type into the chat. We'll address questions after the presentation generally. When there's time for questions, if you want to open your mic up to ask a longer question, you can do that. The chat can be found at the top right of your screen. It looks like a little dialog box. If you just click on that, it should open up the chat window. If you want it to go away, you can click the X at the top right of the screen that comes up with that chat window.
Great, thank you. So Mallory and Allie, I'll turn it over to you.
Excellent. Thank you so much, Eric, and thank you everybody for joining. Obviously, we wish we were doing this in person, but we're so glad you all are joining us virtually. So we're going to start tonight. We have two parts to our presentation, two very different topics. The first, I'll be giving on an overview of HHS's recent finalized interoperability rules, and then I'll turn it over to Allie to talk about nursing home compliance programs. I also want to thank Angela and Bill from MSBA and Eric for helping us put together this virtual presentation. So thank you very much. And with that, I'll jump right into our interoperability presentation. So first, tonight I'm going to give an overview, as I said, of some three interrelated rules. The first is the CMS Interoperability Final Rule. The second is the Office of the National Coordinator for Health Information Technology, Cures Act Final Rule. And finally, I'm going to touch on the end the Office of Inspector General's proposed rule on civil monetary penalties relating to information blocking. Now, these are fairly technical and dense rules. If any of you have taken a look at them, they came with several hundred pages of commentary. So the goal tonight is really just to provide you a brief overview of some of the key provisions, and I'll tell you about who they apply to and some of their effective dates, as well as how those effective dates have been impacted by COVID-19. So I want to start out by just giving you a brief overview of the timeline. And if Bill, if you could advance the slide, thanks. So just to give you an appreciation for how quickly these rules were finalized, the initial rules were the proposed rules were formally published back in March of 2019, and just a little over a year later, in March, HHS informally published the final rules. That was only days before COVID-19 sort of hit its peak or began to hit its peak. So in April, HHS announced that it did intend to impose some implementation delays due to COVID-19 and exercise enforcement discretion to delay some of the various regulations. And I'll touch on those delays in my presentation. The Office of Inspector General, which is charged with imposing civil monetary penalties related to information blocking, just issued their proposed rule at the end of April. And on May 1st, HHS formally published the CMS and ONC final interoperability rules. Next slide, please. Thank you. So I wanted to start by providing a definition of interoperability. And the definition you see here actually comes from the 21st Century Cures Act, which was enacted in 2016. And the goal of that legislation was to improve interoperability as well as prevent information blocking. And it defines interoperability as health information technology that enables the secure exchange of electronic health information with and use of EHI from other health IT without special efforts on the part of the user. And the definition also involves health information technology that does not constitute information blocking. So what that really means and what the goals really are to allow for the easy and secure exchange of data, allowing one health IT system to communicate with another. And just to provide some background, historically there have been a lot of challenges with interoperability, largely around a lack of standardization across health IT systems, so systems cannot always communicate with one another, as well as information blocking practices on the part of providers and IT vendors that are trying to protect their own business interests. And finally, certain privacy concerns have also been a barrier to interoperability. And really that's what the rules on interoperability that I will discuss tonight are meant to address. Next slide, please. So I'm going to start with the CMS Interoperability Final Rule, and I thought it'd be helpful to talk about some of the purposes of that rule to start. So the purposes are to improve patients' access to their health information by allowing them to move from health plan to health plan and provider to provider and have their information travel with them. Another purpose is to make it easier for providers to deliver high-quality care by giving them access to all available data on their patients. And finally, it's meant to have payers be able to exchange data more seamlessly to facilitate care coordination and transitions of care. So on this next slide, it provides an overview of just some of the key provisions of the CMS Interoperability Final Rule. And I'm only going to be talking about the first four this evening, which are the Patient Access API, the Provider Directory API, Payer-to-Payer Data Exchange, a new hospital condition of participation on electronic patient event notices. But there are some other important provisions, including public reporting on information blocking, public reporting of providers' digital contact information, and increased frequency of data exchange on dual eligible beneficiaries. So in the first part of the CMS rule, I'm going to talk about the Patient Access API. So this part of the regulations that have been enacted apply to what I will refer to as the plans throughout this presentation. And that means, oh, next slide, please. So the plans means essentially Medicare, or a lot of Medicare and Medicaid regulated plans. So Medicare Advantage organizations, Medicaid fee-for-service programs and managed care plans, children's health insurance programs, and managed care entities, and qualified health plans issued in the federally facilitated exchanges, with a few exceptions that are noted on the slide. So this requirement of the regulations, it requires these plans to implement what are called application programming interfaces that will permit third-party applications to retrieve, with the approval of plan enrollees, specified data through the use of common technologies. So to boil that down a little bit for you, it essentially requires these plans to make data interfaces available that will connect to the health plan's data, and it will allow patients through these what are called APIs to access their health information through software applications connected to personal devices or their computers. And the effective date for this provision was initially set for January 1 of 2021, but due to COVID-19, CMS has indicated that it's not going to enforce these provisions until next July. So what content must be made available through these APIs? Within 1 business day of receipt, which is a pretty quick turnaround, the plans are required to make the following data available: data on adjudicated claims and enrollee cost sharing related to those claims, encounter data, clinical data including lab results, and information on the plan's drug coverage. Now, the final rule did introduce a finite look-back period for what data would be required to be produced, and that's any data maintained by the plans with a date of service on or after January 1 of 2016. So next slide, please. The plans are also required to comply with certain technical requirements. They must use API technology that conforms with ONC standards. And I'll talk about in a little bit, ONC has introduced new API standards as part of its interoperability rule. The plans must also conduct routine testing and monitoring of their APIs to ensure they have implemented appropriate privacy and security features so that comply with HIPAA and other applicable laws. So those of you familiar with HIPAA, that essentially means making sure you're applying your regular risk assessment to these technologies. The next requirement for the plans related to the patient APIs is they have to make easily accessible on their websites and through other methods information for their enrollees about how to access their EHI through these APIs and some of the privacy and security risks of doing so. Next slide, please. Thank you. So the educational resource they have to provide to enrollees include talking about factors enrollees should consider in selecting an application, the importance of understanding privacy practices of an application, how to file a complaint with the Office of Civil Rights or the Federal Trade Commission, and the types of organizations that are governed by HIPAA. And to provide a little background here, the third-party apps that will have access to enrollees' data are not governed by HIPAA. And so many privacy and security concerns were raised with CMS during, as part of the proposed rulemaking process. And CMS essentially has said that it's not the plan's decision ultimately to decide how an individual chooses to access their information. So instead, they've required the plans to sort of provide notices to make enrollees aware of privacy and security issues that may exist. But it's also ultimately up to the enrollee to decide whether or not they want to have their information sent to these third-party apps. The next requirement related to the patient APIs is that the technology must be made publicly accessible to allow all health IT developers to access them in order to increase competition. So the plans essentially have to publish a playbook of how third-party apps can connect to their APIs. And a final limitation on the patient APIs is that the plans may only deny or discontinue a third-party application's connection to the API if they reasonably determine, consistent with their HIPAA security risk assessment, that the connection to the API presents an unacceptable security risk, and that they make this determination using objective, verifiable criteria. So essentially that they don't make this decision in a non-discriminatory manner. So that's it for the patient API portion. I'm next going to give just a short overview of the provider directory API. So again, this portion of the regulations applies to the plans that I previously described, except for qualified health plans on the exchanges, which are already subject to this requirement. And the effective date for this portion of the regulations is also July 1 of next year. So for this requirement, the plans must implement and maintain a publicly accessible API on their websites that provides their enrollees a complete and accurate directory of all the contracted providers in their network, as well as the pharmacy directory. And the goal of this part of the regulations is to improve patient health by connecting them with all their appropriate providers. So next, I'm going to touch on the peer-to-peer data exchange. So this portion of the regulations applies to Medicare Advantage organizations, managed care plans, and qualified health plans in the federal exchanges. And this portion of the regulations is effective as of January 1 of 2022. So The requirement for this portion of the regulations is that these plans are required to maintain a process for electronic exchange of specified data on their enrollees. And when the enrollee or their personal representative requests the information, the plan has to be ready to receive all data on enrollees that it has covered within the preceding 5 years, as well as send data to other payers that may have covered the enrollee in the past 5 years. And so the real goal of this is to make for easier data exchange between payers to improve care coordination and patient access, to ultimately allow patients to create a cumulative health record of all their electronic health information. Another goal of this provisions is to create efficiencies for providers in order to avoid duplicative tests and services that may have already been provided to the enrollee. Lastly, as part of the CMS rules, I'm going to touch on the new hospital condition of participation, which involves electronic event notices for certain events. So for this particular regulation, it applies to hospitals, psychiatric hospitals, and critical access hospitals. It was initially set to go into effect this November, but due to COVID-19, CMS has delayed it until next May of 2021. So the requirement for this new condition of participation is that if a hospital utilizes an electronic health record system or an EHR system or other electronic administrative system, it has to be able to demonstrate that, one, its EHR notification capacity is fully operational and used in compliance with applicable law, that it has the capability to provide notifications, including at a minimum a patient's name, a practitioner's name, and the sending institution's name. And it has to be able to provide these notices, next slide, thank you, for specific events. So the regulation says, to the extent permissible under applicable federal and state law and not inconsistent with the patient's expressed privacy preferences, the hospital has to send notifications at the time of the following events: registration in the hospital's emergency department, admission to the hospital's inpatient services, or the patient's discharge or transfer from the hospital's ED or inpatient services. And the hospitals are required to provide these notices to all applicable post-acute care service providers and suppliers, as well as the patient's primary care provider or practice group, or another practitioner identified as responsible for the patient's care. So that's a very quick whirlwind tour through the CMS, some of the key provisions of that rule. And I'm now going to turn our attention to the Office of National Coordinator, Cures Act final rule. So similar to the CMS rule, there's a lot of overlapping purposes here, which are to advance interoperability and support the access, exchange, and use of electronic health information, as well as address information blocking. So some of the aims of this rule in particular are to give patients greater access to their EHI by making it more electronically accessible through the adoptions of standards and certification criteria that apply to health IT developers. It's also supposed to promote healthcare choice and competition by improving access to electronic health information, allowing patients to make more informed decisions. Next slide, please. So the ONC Cures Act final rule is meant to implement certain provisions of the 21st Century Cures Act, which went into effect in 2016. And those provisions include creating regulations that define reasonable and necessary activities that do not constitute information blocking, as well as implementing updates to the 2015 edition Health IT criteria and the ONC's voluntary Health IT certification program. It also implements what are called conditions of maintenance and certification requirements for health IT developers. And for those of you familiar with conditions of participation for Medicare, it's very similar to that in that it's sort of a code of regulations that apply to these health IT developers. So given our timing tonight, I'm just going to be able to give you a brief overview of the information blocking regulations and penalties. I will note though, on the previous slide, the updates I was referring to about the updates to the 2015 edition of the Health IT criteria as well as the conditions of maintenance and certification, those apply to certified health IT developers. And they essentially are putting into place a lot of new standards and criteria that will apply to the certified health IT products by health IT developers. And I did want to mention just one of those criteria as it relates to the CMS rule I was talking to, which is that all health IT developers that have certified health IT products are required as one of the new criteria to have standardized API services that they provide both for single patient use, meaning an API that will connect to third-party apps that can be used by patients, as well as population health services that can be used by both payers or plans and healthcare providers to perform certain population health service initiatives through applications. And so to bring a little context to this, for those of you who may represent different health plans or payers, as I was describing previously for the CMS rule was very focused on creating and implementing APIs, but those rules applied specifically to Medicaid and Medicare managed plans. The ONC rules are much more expansive than that, in that they apply to all products offered by certified health IT developers. And so this can have a much broader reaching impact, in that these rules are going to make APIs much more broadly available because most plans and most healthcare providers do use certified healthcare IT technology. And so with that, I'm going to jump into the information blocking exceptions. Next slide, please. So the ONC Cures Act final rule amended the Public Health Service Act by defining certain practices that constitute information blocking and authorizing the Secretary of Health and Human Services to promulgate regulations that would identify exceptions that are reasonable and necessary activities that do not constitute information blocking. And these regulations will go into effect this November 2nd of 2020. But one important thing to note is that the Office of Inspector General is charged with enforcement of penalties related to information blocking, and it is still in the process of finalizing its regulations, which I will talk about at the end of my presentation. And just to provide a little context, so the information blocking provisions were enacted in response to a lot of concerns that were raised with Congress that individuals and entities were engaging in practices to limit the availability and use of EHI in furtherance of their own business interests. So a lot of the provisions I'll be talking about were meant to increase access to EHI and increase competition. So I wanted to start by providing the definition of information blocking, and this is how it's defined both in the Cures Act as well as in the newly adopted regulations. So information blocking is defined as a practice that is likely to interfere with access, exchange, or use of electronic health information. And the exceptions to this are those that are practices that are required by law or those that are covered by an exception that is adopted by the Secretary. Now, the Cures Act, the information blocking provisions do have certain intent-based provisions, and they create different standards that apply to the different actors regulated by these provisions. So the first group of actors are health information technology developers, health information exchanges and networks, and the standard that applies to them is they must know or should know that a practice is likely to interfere with, prevent, or materially discourage the access, exchange, or use of electronic health information. There is a different standard that's been adopted with respect to healthcare providers, and it says that the provider must know that such practice is both unreasonable and likely to interfere with, prevent, or materially discourage the access, exchange, or use of EHI. So it's a much higher standard that applies to the healthcare providers. And on the next slide, you'll see that these provisions, the information blocking provisions, apply to three categories of actors. The first is healthcare providers, And I have the definition here on the slide, which, as you can see, is an extremely broad definition, as it's defined in the Public Health Services Act, to include hospitals, skilled nursing facilities, federally qualified health centers, physician and practitioners, just to name a few. These provisions also apply to two other categories of actors. Next slide, please. And those are health IT developers of certified health IT, which are defined as individuals or entities other than a healthcare provider that develop or offer one or more certified health IT modules under ONC's voluntary certification program. And the final group of actors are health information exchanges and health information networks, which are defined as individuals or entities that determine, control, or have the discretion to administer any requirement, policy, or agreement that permits, enables, or requires the use of technology or services for access, exchange, or use of EHI among more than two unaffiliated individuals or entities for treatment, payment, or healthcare operations purposes. And that is a major mouthful, so to boil that down a little bit, health information, this essentially means that for those organizations that can control the exchange of data between two or more unaffiliated individuals or entities, that is essentially what is a health information exchange or network. And the commentary to both the proposed rule and final rules clarify that both health plans and health providers could ostensibly fall into this category. Next slide, please. So as part of the commentary to the federal regulation, or to the final regulations and the proposed regulations from ONC, ONC provides some description of what examples of what would constitute information blocking practices. And ONC also states that this is not an exhaustive list, and I've just selected a few of these to share with you, just to give you some context for what information blocking practices could implicate both the statute and the regulations. So the first is a practice that restricts access, exchange, or use of EHI for an otherwise permissible purpose. And the commentary of the regulations provides the example that if you have a health system that's requiring its staff to obtain written consent before sharing a patient's EHI with an unaffiliated provider, even though written consent is not required by state or federal law, that could be considered information blocking. Another example is implementing health IT in non-standard ways that are likely to restrict access, exchange, and use of EHI for exporting complete data sets or transitions between IT systems. And the example ONC provides is that if a healthcare provider wants to switch its EHR system, and its current EHR system will only provide data in a PDF format, even though it's available in many other formats, that could be considered information blocking. The other couple examples that I'll provide are that disabling or restricting capabilities that enable users to share EHI, or implementing capabilities in ways that create unnecessary delays or response times. So again, those are not an exhaustive list, but just a few examples of some practices that could implicate the information blocking rules. And so as part of these regulations, ONC has defined 8 exceptions that offer actors certainty that their practices will not be considered information blocking, subject to penalties and enforcement, when they meet all conditions of the exception. And so if a practice does not meet all conditions of an exception, it will not automatically constitute information blocking. Rather, ONC, or rather OIG, will evaluate on a case-by-case basis whether it constitutes information blocking. And so just as a reminder, this is an intent-based statute, so it will operate much like those of you that are familiar with the anti-kickback statute and its exceptions, it will operate in a very similar manner. So now I'm going to run through just a brief overview of what the exceptions are. So the first 5 exceptions involve not fulfilling requests for access, exchange, or use of ePHI. So this grouping of exceptions basically says that it is not information blocking if an actor engages in practices that are reasonable and necessary to 1, prevent harm to a patient or another person, to 2, protect an individual's privacy, to 3, protect the security of EHI. The 4th exception deals with not fulfilling a request due to infeasibility. And the 5th exception involves making health IT temporarily unavailable or degrading its performance for the overall benefit of the health IT. So essentially, if there's some kind of problem with the health IT system, taking it offline for some time in order to fix it. And for each one of these exceptions, they are essentially a safe harbor, but only if you meet the specified conditions. And I will say, for those of you that haven't looked at the regulations, they are pretty technical regulations with a number of different conditions that must be satisfied. And for exceptions 1 through 4, for those of you that are familiar with the HIPAA rules and cover various covered providers or health plans, there is some overlap with certain HIPAA regulations. However, I think in order to come into compliance with this set of rules, it will require some review and potentially updating existing policies or developing new policies, because many of these exceptions layer on some additional requirements. And just to provide an example of that, for the infeasibility exception, it requires an actor to provide a response within 10 business days of receipt of a request, explaining why the request is infeasible. And this 10 business day requirement, for those of you familiar with HIPAA, could be a much shorter time frame than what HIPAA provides to respond to general requests for access. So that's just a brief overview of the first 5 exceptions. The final 3 exceptions involve procedures for fulfilling requests to access, exchange, or use ePHI. So for this grouping of exceptions, they basically say it is not information blocking the 6th exception is to limit the content and manner of a response. The 7th exception is to charge fees, including fees that result in a reasonable profit margin. And the final exception is to license interoperability elements for EHI access or exchange. And so again, like the prior group of exceptions, you have to meet all of the various conditions, some of which impose shorter timeframes than you would typically see for HIPAA-related regulations. And so it again will require some review of policies in order to bring covered actors into compliance. So I'm going to wrap up tonight with just talking about the information blocking civil monetary penalties at stake for these various information blocking practices. So the Cures Act granted the HHS's Office of Inspector General, next slide please. Thank you. So the Cures Act granted OIG authority to investigate and enforce claims of information blocking. And as I mentioned at the beginning, the OIG just put out its proposed rules for the civil monetary penalties at the end of April. And so penalties for health IT developers, health information exchanges, and health information networks are proposed to be the following. They will be subject to a maximum civil monetary penalty of $1 million per violation, which is for each practice that violates the information blocking regulations and they do not satisfy an exception. OIG has stated that
Hi, Mallory. It appears you've frozen. I don't know if you can hear us, but maybe try refreshing or rejoining. Hi, Allie or Eric, do you want to jump in while we figure out what's going on with Mallory? I can switch the slide deck if Allie's ready to take over. Allie, you're muted right now. You're gonna have to unmute yourself.
Oh, sorry.
Oh,
Yes, it looks like Mallory lost power, I think.
Okay,
yeah,
well,
I saw that email we just got, Ally. Um, I guess we can proceed. That was great, very informative. I also look forward to hearing Mallory's response to Julian's question. But with that hard stop of losing power, I guess maybe Ally, if and Bill, if you can facilitate getting Ally's slides up, and you want to get started on the skilled nursing facility portion.
Sure. All right, so I'm going to be talking about the new CMS Nursing Home Compliance Program mandate. So I'm going to start first with going over some background about what the new CMS regulation requires of skilled nursing facilities, and then also discuss some strategies on how to create and implement an effective compliance program that will meet those new CMS requirements. Okay, next slide, please. So as a little bit of background, here's the timeline about how we got to where we are now. Back in 2000, the HHS OIG issued some voluntary guidance for nursing facilities on how to develop an effective compliance program, but at that point there was no regulatory requirement that one be in place. In 2010, the Affordable Care Act added a requirement that nursing facilities implement a compliance program. And then in 2016, that was implemented by CMS regulation, making an effective compliance program a condition of participation in Medicare and Medicaid, with an effective date of November 28, 2019. Next slide, please. Then on July 18th, 2019, CMS actually issued a proposed rule that would have modified some of these new requirements for the compliance program. And notably, it would have delayed implementation of this requirement for 1 year. However, after the comment period closed in September, there has still not been any new final rule implemented. And so the original CMS rule went into effect on November 28th of 2019. So the scope of the compliance program mandate is that it applies to all operating organizations, which are defined very broadly as any individual or entity that operates a facility, facility being skilled nursing facilities. So any organization that operates a skilled nursing facility is now required to implement a compliance program. And the regulation defines compliance and ethics program extremely broadly as a program that has been reasonably designed, implemented, and enforced so that it is likely to be effective in preventing and detecting criminal, civil, and administrative violations of the Social Security Act and in promoting quality of care. So an effective compliance program under this regulation is intended both to promote compliance with applicable law, but then also to identify and address violations of the program itself. Next slide. So I'm going to go over some of the specific requirements of the CMS regulation now, starting with the requirement to establish written compliance and ethics standards, policies, and procedures. Next slide, please. So in particular, there are a few policies that have to be implemented by nursing facilities in order to comply with the new regulation. And that includes having a policy that designates an appropriate contact person who can receive reports of suspected violations, either made internally through various staff members or contractors of the facility, or also from the outside, from possibly residents or their families. The facility also needs to create a method to receive anonymous reports, and it must have policies dealing with the disciplinary standards that will apply to various levels of violations and apply to different categories of people who could potentially violate the compliance program, such as staff, contractors, and volunteers. And then next, facilities must assign specific individuals that are considered high-level personnel to oversee compliance with the program. And CMS has a specific definition of high-level personnel, meaning that it needs to be an individual that has substantial control over the organization or has authority to make organization policy. And so as an example, this could be someone like the chief executive officer or an executive director. It could also include members of the board of directors. And so in addition to appointing someone to oversee the program, there must also be steps taken to make it so that they can effectively guide and oversee the compliance with the program. And that includes providing adequate resources and authority to those who are involved with overseeing the program, and then also making sure that whoever is designated with responsibility of the program doesn't have a history of non-compliance or other violations that might make it seem like they are not the appropriate person to ensure compliance. So once the organization has created policies and procedures and designated someone to oversee the program, the organization also needs to effectively communicate these standards and policies to all members of the workforce, including staff, contractors, and volunteers. And there are several ways that this can be achieved. It can be achieved by distributing information that explain the program's requirements, such as through something like an employee handbook or disseminating new policies as they're created. But the organizations must also provide mandatory trainings to employees and could have mandatory training as part of their orientation or onboarding for new employees as well. Right. And then the next step with all of this is that the organization must actively take steps to make sure that it is achieving compliance with the policies and procedures that it's put in place. So to do so, there has to be a way to effectively identify problems and violations of the program. And CMS has imposed a few different ways that organizations need to actively be assessing their compliance with their program. Organizations need to do internal monitoring and auditing of their own employees and try to detect any sort of civil, criminal, or administrative violations by staff. But there also needs to be a publicized reporting system for staff members and others to provide their own reports of violations. And so the only compliance oversight should not come just from internal monitoring, but also there should be a culture of promoting internal reports of violations as well. All right, next slide, please. And then finally, the organization also needs to consistently enforce its policies and procedures by following through with the disciplinary actions that it has identified in its required policies and procedures to begin with. And there should be a focus not just on remedying identified instances of misconduct, but also on failures to detect and report violations, because the compliance program should always be working to identify as many places for improvement as it can, and part of that comes with having a culture where employees and other staff members feel comfortable making those reports. Next slide. There must also be a procedure to respond to violations of the program and prevent similar violations in the past. And this requirement essentially says that nursing facilities should learn from their mistakes, and they should always be making ongoing modifications to their compliance programs as they identify new risk areas or identify past violations. So this is not something that should just be put in place once and never touched again, but it should really be sort of a living program that adjusts and addresses various need areas as they arise. Next slide, please. There is also a requirement that organizations review the program annually and revise it as needed in order to reflect various changes in the law that may have come about, also to reflect changes within the organization, and again, just improve performance with various risk areas that have been identified. And there are a couple of special requirements that apply only to large organizations, which CMS has defined as operating organizations that have 5 or more nursing facilities under their umbrella. So the first of these is that large organizations need to hold mandatory annual trainings. Smaller organizations do have a mandatory training requirement, but CMS did not provide any specified time frame for when those trainings need to occur. large organizations also have some extra obligations when it comes to the individuals that are put in charge of overseeing the program. So there must be a designated compliance officer whose primary role is to oversee compliance with the compliance and ethics program. Whereas for smaller organizations, there does need to be someone who is in charge of overseeing, but that doesn't necessarily need to be their primary responsibility within the organization. And this designated compliance officer must have a certain degree of autonomy within the organization. They cannot be directly subordinate to various officers or general counsel, and that is designed to ensure that this person has autonomy and feels as though they can take whatever actions they need in order to make sure that the compliance program is effective. And then similarly, there has to be a designated compliance liaison at each of the facility within these large organizations. So as I mentioned when we reviewed the timeline, CMS proposed some changes to this rule back in July of 2019, and those would have kind of relaxed a lot of the requirements that we just discussed. Particularly, it would remove the requirement for large organizations to have a designated compliance officer and compliance liaison at each of the individual facilities, and instead they could designate someone similar to the smaller organizations. It also would have removed the requirement for the compliance contact person to receive reports of violations, and it would give organizations more flexibility in how they implement a reporting procedure and who should handle various reports. Next slide, please. It also would require large organizations to review their programs on a biannual basis rather than annually. And it would again provide some more flexibility in who organizations can designate as the person who's in charge of overseeing the program. And then finally, most importantly, it would have delayed implementation of the nursing home compliance mandate until 1 year after the effective date of the regulation. However, that 2019 proposed rule has still not been finalized. Next slide. So the compliance program mandate, as it was originally written in 2016 and with the requirements that we've just discussed, did go into effect on November 28th, 2019. And as part of the commentary to the final rule back in 2016, CMS did indicate that it would issue sub-regulatory guidance on these various requirements, including interpretive guidelines for surveyors that are typically issued for other regulations that facilities are evaluated on when they are surveyed by the state survey agency. However, the interpretive guidelines and sub-regulatory guidance has not yet been issued. So, in light of the absence of any sub-regulatory guidance from CMS directly on this mandate or any interpretive guidelines explaining how facilities will be surveyed in order to establish compliance with this requirement, I thought it would be a good idea to go through some tips and best practices on how to develop an effective compliance program. And a lot of these are guidance points that were identified by HHS OIG back in 2000 in its initial voluntary guidance, but also some tips that have been pulled from other more recent guidance as well. So one of the first requirements under the CMS compliance mandate is to create effective policies and procedures. And next slide, please. One way to identify how to prioritize policy and procedure development is to begin with an enterprise-wide risk assessment. And this can really help identify different areas that may need more policies or more procedures or more guidance for staff members in order to ensure compliance. And conducting a risk assessment is very useful for specific facilities to determine what their particular risk areas may be. So for example, record keeping and documentation or billing and cost reporting may be high risk areas that could lead to potential false claims liability, whereas prior surveys in which there are identified deficiencies related to residents' rights or quality of care could be a good place to start in order to develop some more robust policies. So along those lines, it always helps to review existing policies and procedures and to compare with various reports or violations or identified deficiencies on prior surveys to see if there is an area that potentially needs improvement. Facilities should also prioritize policy and procedure development on their identified high-risk areas, which again can vary across organizations. It should also involve employees of all different roles to make sure that everybody is captured under policies and procedures and that everybody understands what their obligations are with respect to the specific compliance program. And then finally, policies obviously should be clear and understandable. They should delineate specific roles and requirements so that they can be easily followed. All right. And then next, there's a lot of requirements in the CMS compliance program mandate related to who should be put in charge of overseeing the program. And so some general guidance on choosing effective leadership is that an organization should look for a person who can be objective, independent, and who has a reputation for integrity. But effective compliance officers also need the appropriate amount of time and resources to devote to their job to make sure that they actually have the ability to regularly review policies and to think critically about how to improve various aspects of the organization. And this is an opportunity to create various committees as needed, particularly for various risk areas, such as having a residence rights committee or a committee that's more focused on billing compliance. All of those go into the determination of effective leadership. Next slide, please. Next are some tips on how to educate the workforce, because obviously having tons of policies and procedures that are in place is a great thing, but it doesn't do very much if those who are supposed to be following those procedures are not properly educated on what is required. So first on this visual is developing and implementing regular, mandatory, and effective education and training for employees. This is another opportunity where education can really be tailored depending on what role certain individuals have within the organization and what department they may be working in. And training doesn't necessarily need to look the same across the board. And so there should be focused trainings for each different role that communicates their specific obligations with respect to the organization. In terms of preparing for surveys on what this organization, or on the education portion, there should always be documented attendance to ensure that everybody is captured by these education seminars. And then as policies and procedures change or as things update with the organization, training materials, just like policies, should be routinely revised and disseminated on a regular basis. So there's a lot of reference to having an effective complaint communication or reporting process in the regulation. And in particular, it is very helpful to have a confidential and non-retaliatory policy that is specific to complaint reporting, that even if there is a procedure in place that details how organizations will receive anonymous reports, it's helpful to have another policy that specifically mentions how information will be kept confidential and that employees or others that do decide to report non-compliance will not be retaliated against. The anonymous reporting process can take a lot of different forms. There could be an anonymous hotline that's set up where individuals can call in and leave voicemails and then have someone designated to review those messages and forward them to whatever appropriate individual should be addressing those complaints. There could also be anonymous suggestion boxes or other anonymous reporting mechanisms, but basically anything that can encourage open lines of communication along with no fear of retaliation. And then once the complaint is investigated, there should be disciplinary processes that are followed consistently. Sorry, we can go ahead to the next one. Finally, making compliance with the program should be an ongoing priority. And so this ties back into every stage of how to effectively create policies and keep people compliant with them, such as conducting regular audits and risk assessments. So audits are very important for identifying potential violations, but risk assessments are vitally important in order to continue to identify problem areas that the organization may need to address through its compliance program. Organizations can also consider using both internal and external evaluators. So they could potentially engage an outside consultant to do a mock survey that might identify some areas that aren't captured through an internal audit. The organization should also have a focus on assessing reports, complaints, and violations, and then following through with disciplinary procedures on those points as well. And then if there's a history of certain areas that have led to deficiencies on prior surveys, those should always be a focus of revisions to the compliance program. So with all of that in mind, even though there's not clear guidance yet from surveyors or from CMS as to how facilities will be evaluated on their compliance with this new regulation, there are some general tips to take away about what to expect during a survey. So facilities should expect that surveyors will interview staff members, and these interviews could cover a broad array of topics, but it will likely include questions about whether the staff members are familiar with particular aspects of the compliance program, if they know how to make a report of a violation, potentially who's in charge of overseeing compliance if they had something to report and wanted to speak to someone, and then also to assess their general knowledge of the policies and procedures. Second, because there is a mandatory training requirement as part of the regulation, facilities should be prepared to make documentation of that training easily accessible to prove that they have complied with that requirement. And then finally, because policies and procedures are sort of the baseline requirement of the compliance program to begin with, it's always helpful to have hard copies of policies or to have electronic copies if they're easily available that you could pull out to show to a surveyor, but then also to ensure that staff members who may be interviewed or come in contact with the surveyors know how to access those as well. All right, we can go to the next one. So I did want to touch on the current situation of nursing home surveys with COVID-19, given that there has been a lot of change over the past few months as to what is being prioritized by CMS and by various state survey agencies. If you go to the next slide, please. Thanks. So on March 4th, CMS officially suspended all non-emergency inspections of nursing facilities. And instead, state survey agencies were directed to prioritize only complaint surveys for immediate jeopardy level complaints, complaints of abuse and neglect, or complaints related to deficient infection control processes. And a couple weeks later, CMS provided some more tailored information about how to conduct a focused infection control survey tool. And so that has really been the focus over the past few months in terms of the state survey agencies. And it seems like that is likely to continue. CMS has just issued some more guidance directing states to conduct more of these focused infection control surveys, and has stated that states' CARES Act funding may actually be at risk if they don't meet the specific percentage survey performance goals that CMS is giving them. So for the time being, there will definitely continue to be a focus on sort of the most severe complaints and infection control related complaints. And so the nursing home compliance program aspect of a survey is not necessarily at the forefront of the picture right now. However, it does seem as things continue to open up that regular surveys may continue soon. And so that's something that is definitely fair game once that happens. So the next slide. CMS actually just issued some new guidance earlier this week about how states can start to return to their standard surveys. So it's provided a new category of complaints or different types of inspections that can resume once states meet phase 3 of the CMS nursing home reopening guidance. And obviously this will differ from state to state, but it's kind of broad criteria that basically if states feel that they have adequate staffing, adequate supplies of PPE, no new COVID cases for 28 days, and a sufficient store of cleaning and disinfecting equipment, then they may be able to start returning to standard surveys. And so whenever that happens for Maryland is when we'll start seeing some more surveys that will probably focus on addressing whether the facility has complied with this new nursing home program mandate. So that's all we have for you today.
I thank you very much, and Mallory, thank you very much. I'm sorry for the technical difficulties, but glad to see you're back with us. Did you want to, Mallory, wrap up with a few thoughts on the interoperability rules, and then to the extent anyone does have questions, feel free, or they can follow up with you offline. Absolutely.
Sure, thank you for that. Yeah, I was just getting to my last slide, but basically where I left off was that OIG has proposed penalties of $1 million per violation for health IT developers, health information exchanges, and health information networks. However, for healthcare providers, which is the other group of actors, the Cures Act calls for referral to the appropriate agency to be subject to disincentives using authorities under applicable federal law as set forth through additional comment and rulemaking. So essentially, right now, as of now, OIG is still evaluating and collecting information on what disincentives and what penalties will look like for healthcare providers under the information blocking rules. But at this point in time, they have said they may refer violations of the privacy and security rules to the Office of Civil Rights, who enforces HIPAA violations. But we don't know as of yet what the other disincentives or penalties could look like. And the Cures Act specifically says, to the extent possible, HHS should avoid duplicative penalties. So essentially the jury's still out on what penalties healthcare providers could be subject to other than the penalties already available under HIPAA if the practice would violate the privacy or security rules. So I was going to wrap up my presentation just by saying there's a lot of changes coming, especially with health IT certified products in the coming months, in the next year to 2 years. And then the CMS rules obviously will present some new technologies and additional interoperability for those specific plans I talked about. But for those of you that that may represent various actors covered by these rules, it is worthy of evaluating, especially the information blocking rules, to see how those might apply to particularly health plans and health providers, because I think it's still very much it's very much kind of comparing those practices with HIPAA to figure out where there's similarities and what policies and contracts may require update as a result of these new regulations. So with that, I will say again, thank you to our MSBA host and Eric, and we'll open it up to the group for questions. And I'm going to check the chat to see if we've received anything.
Hey, Mallory, you're not going to see some questions because you left. There were a couple that came in when you were giving your presentation. One was, are HIPAA compliant apps in development by third-party providers?
So that's a good question. And so a lot of times the term HIPAA compliant is used, and what people think of usually when they think of that is that the third-party app is capable of meeting the various security requirements that apply to business associates, because generally third-party apps are not directly regulated by HIPAA, but they can become regulated by HIPAA by becoming a business associate, by providing services to health plans, healthcare providers, or healthcare clearinghouses, which are the traditional covered entities under HIPAA. And so I think there very much are some third-party apps that are in the process of getting vetted. And the reason I know this is we do have some clients with, it's very popular in Maryland, is one of the major EHR systems is Epic. And I know that they've been vetting various third-party apps for various security functions. So I think there certainly are some third-party apps that have strong enough security practices that they could be considered a compliant business associate. The key question, though, about whether they are HIPAA compliant is a third-party app will technically not become regulated by HIPAA at any point. unless they're engaged by a covered entity to provide certain services. So in a lot of the ways I was describing in my presentation that they might receive data at the direction of a health plan enrollee or a patient, that would not necessarily mean that the third-party app has been contracted by a health plan or provider. It may just mean that they have the health plan or provider has allowed them to connect to their API and receive data, but they still, just by reason of that, wouldn't necessarily be regulated by HIPAA.
May I follow up?
So that was a very long explanation, but I hope that makes sense to everyone.
May I follow up on that? Just to clarify, this is Julie Bell, and thanks for both of your presentations. I understand that they would not technically be covered by HIPAA, but what I was trying to get a sense of was whether the security requirements would be such that folks who are, people who are using third-party apps could have some confidence that the level of security was akin to a HIPAA compliant app. And it struck me in your presentation that you made note of the fact that these third-party apps aren't covered by HIPAA. And I was just trying to get a sense of whether the ONC rules for, there's, the ONC standards approximate HIPAA, or whether we're entering sort of a wild west where people are going to be uploading mobile apps that, even though they're ONC compliant, or maybe not, we have this robust HIPAA compliance requirements for covered entities and business associates, but is all that out the window? Basically, if you upload your information to a mobile app, are we suddenly going to see that information grabbed and utilized by, unsavory players? I mean, what's the level of security we're talking about with respect to the ONC standards that apply to these apps?
Well, and that's a very good question. And you raise a really key question that was raised throughout the rulemaking process was, are we putting this information that's been relatively had a lot of regulation and protection over the years when it's held by a health plan or covered entity or health provider, is that now being put at risk by reason of going to the third-party app? And to be honest, I don't know exactly. I'm not sure whether, so a lot of ONC's healthcare certification programs are voluntary. And so different health IT developers can choose whether or not they're going to comply with it, and whether they're going to have the appropriate certifications. So some third-party apps may choose to do so, others may not. And you bring up another interesting point. So the real way of the one enforcement mechanism there will be against these third-party apps is through the Federal Trade Commission. And that's a point that both ONC and CMS make in their rules, that the FTC in recent years has been focused on unfair and deceptive trade practices. So a lot of these apps will be putting out privacy policies, but they won't be anywhere as stringent as like HIPAA's requirements for privacy practices. And so they will be required to be they are supposed to be transparent about how they're using people's data. For example, whether it's being sold to other parties or given to other third parties. But at this time, there's not, because the regulatory environment is so different for health IT apps, and a lot of it is voluntary, that I don't think there definitely won't be as stringent as security requirements or enforcement standards that are available against traditional HIPAA covered entities. And so I think that consumers that are savvy enough to understand that fact and that actually read the notices that their health plans and providers may put out may have some real concerns with sending their data to these apps for this reason. Hopefully those apps will develop good privacy practices just on their own account, or with the understanding that FTC will be watching to some degree. But they definitely don't have the same penalties and as much a stake as traditional covered entities.
Thank you.
Mhm.
The other question was put in the chat was, how expansive will the info be that patients have access to via third-party apps under the ONC rules? For example, has ONC identified standard technical rules for sharing physician notes related to a patient's care?
That is a very good question, and that's I actually ended up trimming that out in account of time. But so the ONC's rules cover what they call electronic health information, and they've put two different standards in place for what it will capture. So they've essentially put in place a 2-year grace period during which the information that's going to be required to be provided under their apps is what's a new standard core data set called the United States Core Data Set that's going to replace, for those of you that are familiar with the CCDS, which is the current standard under the 2015 edition criteria. So for the first 2 years until I think it's May 2nd of 2022, apps are going to have to provide this core data set. And then after that point in time, it will be more expansive, and it will cover what's traditionally known as electronic protected health information as regulated or as defined by the HIPAA rules, which will be a broader set of data. And I can't remember off the top of my head whether physician's notes is part of the new core data set. I will note the new United States Core data set is more expansive, or is meant to be more expansive than the CCDS that it will be replacing. But I'm not sure for certain whether that includes physician notes. Any other questions from the group?
This is Pam Owens. I have a question on the SNF compliance program issues.
Oh, go ahead, Pam.
Thank you. So my question involves a large, if you're part of a large health system that operates multiple hospitals and numerous physician practices, but also one SNF, do you feel as if and those compliance programmatic issues that you mentioned are all met at the corporate level, will they be required to be duplicated at the SNF level, or is a system-wide compliance program that meets all of those requirements you think sufficient?
Yeah, so I mean, I think it depends on how the scope of the system-wide compliance program is defined in the documents that it has. So if it's clear that it extends to all different practices and different hospitals and a skilled facility, then I think it meets all of those requirements in the CMS, then that would be sufficient. However, I do think it's helpful in terms of just best practices for creating policies and procedures that, aside from those small specific ones under the regulation, that there should still be an effort to do a risk assessment on maybe the facility by facility basis, because there can be definitely different risk areas applicable to a SNF than a physician practice. And so just to make sure on an organization level that you're having the most effective compliance program that you can, it's not a bad idea to have specific tailored policies, but an overarching compliance program that satisfies those requirements from the system level would be enough to satisfy the regulation.
Can I jump in a second on that?
Sure.
Basically, what you can be doing is you can have some things that are centralized. For example, your hotline and all your open communication, and even some of your educational training can be enterprise-wide if you have the process. Where it gets down to, as mentioned before, you can still have one compliance personnel as long as you've got the other liaisons at your nursing facility. And then you also have to look at making sure you have your policies and procedures that are structured for the nursing facility, because what works in a hospital is not necessarily going to work in a nursing facility. So what we have is we have two independent living, one assisted living, and then 2 nursing home buildings. So we have a general program, but I know that the policies and procedures that we're going to have in the nursing home are not going to fly for the assisted living, but we're going to have it all under one umbrella. So we make sure that everybody is complying, for lack of a better phrase, with knowing that they have to get these policies and procedures out there and having a central location. So you can mix and match some of the things that can be generalized, in particular a hotline, in my opinion, but other things are just going to have to be more specific.
Yeah, I'd agree with that.
Thank you. And then can I have one follow-up question?
Sure.
You mentioned a survey. I heard you talk a lot about surveys. So are we anticipating that these compliance program requirements are they conditions of participation, or are they conditions of payment, or is it a mixed bag?
So they are now conditions of participation, and so are subject to state surveys. However, there still aren't specific interpretive guidelines that have been put out to surveyors yet on what exactly they should be doing to evaluate whether there is compliance with this condition of participation.
Thank you.
Are there any other questions from the group?
Hearing no more questions, this is where we would give a round of applause. So I will give the virtual thumbs up to Mallory and Allie. Thank you very much. This is very valuable and big contribution to our section. So thank you very much for putting this together and bringing this top of mind. To everyone else, thank you very much for joining. The leadership of the health law section will be going back to the drawing board now to see how we're going to proceed with the plan year in 2020, 2021, but we will be in touch. So monitor your emails to the extent, well, usually, as many of you on the call know, we do some form of elections nomination process at our meetings. At about this meeting is when we would have a nomination process that will not be happening tonight, nor will it be happening in person this summer. So I guess what I'll ask in advance of talking with other leadership of the health law section, if anyone on the call is interested in taking a more leadership role in programming for next year, please do feel free to reach out to me, and I can talk with you about how you can get involved in your interest in the section next year. If we don't hear from folks directly, Kaylin, Leslie, and I will be following up to let everyone know how we're going to plan to proceed for the coming year. But thank you again, everyone, for joining. This was a great virtual turnout for a great program. So everyone stay safe and enjoy the evening. Bill, thank you very much for your IT support, and Angela for your logistical support. Everyone have a good night. Thank you.